Okay, we will get started shortly. Just let everyone trickle in. Um, okay, well, let's get started. So thank you everyone for joining us today for part 5 of our Health Justice Now series at Families USA. I'm Kevin Hahn from the Strategic Partnerships team, and I'll be moderating today's panel, which is titled A Conversation with Health AAPI Advocates. We have a great group of panelists today who range from those who are working in advocacy and also in state and local government. So this will be a great discussion, and we hope that this will be a time to just reflect on the challenges and also the great things that come from our communities. And yes, as you are coming into the webinar, feel free to use the comment section, and also if you have any Q&As, please utilize the Q&A box, and we'll have a section at the end to address those questions. But yeah, so first I'll go ahead and introduce our panelists. So we have Sarah Liu, the Public Health Program Coordinator at Humke Center, which is in Virginia. And Humke Center organizes Asian Americans towards achieving social, economic, and racial justice in Virginia. And next we have Sammy Sapkota, the Behavioral Health Coordinator at the Asian American Health Initiative of Maryland. And the mission of the AAHI, part of the Montgomery County Department of Health and Human Services, is to improve health and wellness of Asian American communities in Montgomery County. We also have Aziza Ahmad, the Policy and Community Advocacy Manager at the Asian Pacific Islander American Health Forum, also known as the Health Forum, which influences policy, mobilizes communities, and works to improve the health of AAPI and Native Hawaiian communities. And finally, we have Yingja Huang, the Assistant Deputy Director of the Healthcare Benefits and Eligibility at the California Department of Healthcare Services, which DHCS is also the backbone of California's healthcare safety net, helping millions of low-income and disabled Californians to access affordable and high-quality healthcare. So with that, we'll get started with the panel. And I wanted to pose this first question to Sarah. As you know, with the COVID pandemic, AAPI communities have suffered, and there's disparities and challenges to access with the COVID-19 vaccine. Can you talk a bit about the vaccine equity work that you are spearheading at Humke Center? And yeah.
Yeah, of course. Thank you for the introduction, Kevin. So we started out the project for vaccine equity for the AAPI community as we saw a need when the AAPI community, like the population, had the lowest vaccination rate when the vaccines had rolled out. So through outreach and engaging with our community, we found that there were multiple barriers that may have been contributing to vaccine hesitancy within the Asian American community. And although we started off by focusing with the Vietnamese and Korean community, just because there's a high population in Northern Virginia, our vaccine ambassadors have also been working hard to do outreach to other Asian communities, such as the Chinese community and the South Asian community as well in Virginia. So in order to assess these barriers, we have been conducting like phone banking and other in-person outreaches to, shopping centers, college campuses, places of faith, and just having like community members fill out surveys for us to get a better understanding as to what's really holding the community from either getting the first or second shot or even the booster shot. So we felt that it was really important to really understand and listen to the reasonings for them not pursuing the vaccine. And we've also been partnering with local community-based organizations as well as health departments all over Virginia in having discussions of the importance of vaccine equity within the Asian American population. And one of the major events that we did have was we partnered with the Fairfax County Health Department, and we created a vaccination clinic where we were able to get folks vaccinated. So that's a little bit about the vaccine equity work that's been happening.
Yeah, that's great to hear that your organization is working not just with partners, but also really engaging with the community to provide these opportunities and vaccine clinics. Just to follow up on that, like as you did outreach, was it challenging as community members and also, as yourself navigating this pandemic to do outreach like in person, virtually to the AAPI communities?
Yeah, absolutely. There have definitely been challenges, and considering that we are still in a pandemic, we did feel that doing in-person canvassing versus phone banking may be more of a better strategy, but at the same time, making sure that we keep our staff safe. We've resorted to a more passive approach of phone banking. Also, just having those difficult conversations with community members. I know that we have faced, not warm responses, or maybe, folks who just don't want to have these conversations. And so when we do face those situations, we have resorted to practicing empathy and just kind of, letting folks know that we're not here to really push the vaccine onto them, but rather opening up discussion and that we are here for them when that time is ready. So it's definitely not an easy conversation to have, but we've been pushing through and changing up our strategy to still let the community know that it is an ongoing problem.
Definitely. And, the pandemic kind of ebbs and flows. We have waves and outbreaks, and it's so vital that, we continue to do that outreach and also organize these events. And so, yeah, thank you so much, Sarah, for sharing. Next, I wanted to turn to Aziza. It's important that API are reflected in the data that informs federal action. And from your work at the Health Forum, like how does current data practices affect the API community? And what are ways to ensure that federal funding is allocated to address the community's health needs?
Thank you for that question, Kevin, and thank you for having me and the Health Forum here today to discuss data disaggregation and many other things that affect AA and NGPAC communities in regards to health. So the Health Forum works, as you mentioned earlier, works to improve access to quality of care for communities who are predominantly immigrant, many of whom are limited English proficient and are new to or unfamiliar with the US healthcare system. And we have longstanding relationships with over 150 community organizations in 40 different states in the Pacific to whom we provide capacity building, advocacy, and technical assistance. And part of all of this is also advocating for greater data disaggregation and data equity. And just to put it in a nutshell, this means greater representation of our communities and ensuring that the stories of our community and the experiences of our communities are heard and told correctly through data, right? So currently, federal data collection standards are guided by the White House Office of Management and Budget Directive 15, and in the health context, the ACA Section 4302. Now, OMB Directive 15 are federal data collection standards on race and ethnicity that was developed in 1997 that separated Asian American from Pacific Islander and Native Hawaiians. And this hasn't been updated since 1997. So it's a huge issue within our community because by just separating those two groups or even three groups, it doesn't tell a complete picture of the struggles, the health inequities in our communities. And there's actually a data summit, a national AAPI data equity summit happening right now as we speak, which my colleagues and other Asian American advocates or AAPI advocates in different fields are at right now to discuss what the administration, the Biden-Harris administration, is doing to address data equity and how this affects AAPI communities that with, for example, the COVID-19 pandemic, federal data shows that, Asian Americans, Native Hawaiian, Pacific Islanders are doing fairly well. But it's how the data is collected and how it's reported to the federal government that is somewhat misleading. We know that the data is collected from the state and local level and then given to the federal government. But the issue with data equity in particular is that states are collecting this data on AA and HPI community in varying degrees. Some states like Florida only collect Asian American, Native Hawaiian, Pacific Islander communities and categorize it under other. So there's this whole two racial groups that are categorized under other, with everyone else who's categorized under other, and then that's reported to the federal government. For the longest time, Texas didn't report AA and HPI data. And they have one of the largest populations. So that's a huge discrepancy on what kind of COVID-19 data is out there, and working with now the federal government on how to alleviate those data gaps. Because we know that, the federal data right now doesn't give an accurate picture of what's happening on the ground for AA and HPI communities. Just to give an example, for Native Hawaiian Pacific Islander communities, of the 22 states that actually collect the data on NHPI communities, 16 of those states show that NHPIs have the highest infection rate amongst all racial groups, not only within the AAHPI umbrella, but with all racial and ethnic groups. And that just gives you a tiny bit of what the struggle is right now with data equity and data disaggregation. And it's that data that's also used to guide federal funding for certain communities, for our communities. And it's our work to show that not only do we need data disaggregation to show the varying degrees of difference within the AHPI community and the different socioeconomic realities of each community, but also, it directly correlates to how our communities are funded. So if the data shows that, Asian Americans are doing well with COVID-19, why should we fund these groups? And the other thing we're trying to compensate for is within the COVID-19 data is not only showing the data gaps, but showing the reality. I want to go back on this because, again, we're shown that Asian Americans are doing fairly well. But for Asian Americans in particular, not concerning NHPI communities, in 2021, COVID-19 is the third leading cause of death. So how do we correlate the data that shows like, oh, we're doing fairly well with now COVID-19 being one of the leading causes of death, and showing that, right? So there's a lot of work in data equity and data disaggregation because it all kind of correlates with one another. And we need to show that for federal funding in particular, that there's more than what the data shows, and showing the stories that are within those gaps that are not represented in the federal data.
Yeah, and that's so important that you raised that point. Data collection, data equity really does produce those tangible correlations in terms of making sure that people can get the help and the funding they need. And I think That's so important to keep in mind as we keep pushing our state, federal government, local officials to really know that our communities need to be heard, that we're not just one monolith, that, even within the AA and HPI community, there's so many like groups and people who identify and intersect. So that's definitely something that we hope to continue uplifting together. So thank you, Aziza, for that. And next, I wanted to talk more about the ongoing Medicaid redeterminations work that is happening around the country. Something that also Families USA is working on. And for those who um, need more information, so once the public health emergency ends, then people will have to be redetermined into Medicaid, and that's going to affect millions of people, including those in our AAPI communities. And so this question is for Yingzhe, who is working on this issue. Can you talk about more how your department and your office is planning for the end of the public health emergency, and how you are also considering the AAPI communities as well?
Sure. Good morning or good afternoon in the East Coast. I'm Yingzhe Huang, the Assistant Deputy at Healthcare Services, which is the California Medicaid agency. So thank you, Kevin, for the introduction. So just a little context. During the COVID-19 public health emergency, which is still ongoing, the Medicaid redeterminations process was paused since March of 2020. What that means is, on a usual basis, any individual in Medicaid will be determined once a year by the Medicaid agency to re-verify their eligibility for ongoing coverage. In the state of California, currently we have 14.7 million individuals on the Medicaid caseload. We cover that many lives, which is the largest in the United States. And our coverage has increased 16% since March of 2020. And that's largely because of the fact that we cannot redetermine and discontinue individuals through the normal churn process through health coverage. And so for California, we definitely have a pretty daunting task, similar to all the other states nationwide. So currently one of the biggest kind of items on the federal front from an agenda perspective is looking at the best strategy to how to strategize the whole redeterminations caseload throughout the nation, because we're looking at potential coverage losses from every part of the world, in every part of the United States. California itself is anticipating about 2 million lives that will be discontinued as part of the normal redeterminations process when it does commence and when the public health emergency terminates. So right now, the COVID-19 PHE is determined at the federal level. And currently the date for its termination is July 16th or maybe 15th, 2022. But because Medicaid is a full month coverage, so we will be providing coverage through the end of the month. However, right now, the federal government has committed to a 60 days prior notice, which was not delivered to the states. So we anticipate another 90-day extension of the public health emergency through the month of October of 22. And what that means is once that termination does occur in the month of November, we anticipate the resumption of normal eligibility operations for the Medicaid agency. Now, zooming in on kind of the California context, we currently carry about 14.6 million lives on our caseload. About 1.4 million of those individuals are reported on the application as Asian. That's 10% of our caseload. And 10% doesn't sound very much, but when you quantify that in terms of the volume we have, there's many lives in terms of kind of how we're trying to figure out the best strategy to protect. So in California, as part of the unwinding process, our goal is to make sure and mitigate any coverage losses. And what we will be doing is trying to make the process as simple as possible for the beneficiary. Many of them have not been redetermined or contacted by state or county government for 2 years. Now that familiarity may be there for some of them, but we do have many people coming onto coverage during the course of the pandemic. And just kind of looking at the age spread of the folks that have provided information to us in that 10%, we have about 300,000 K across all age groups, whether it be under 19, 19 through 65, 65 and older. So it is a pretty kind of equitable distribution among all age groups in the Asian community for the Medicaid program in California. So what we have been doing, one of the top priorities of the department right now is we have a launch communications campaign where phase 1 is targeted to all individuals in the Medicaid program to update your contact information. And now that's critical because with 2 years elapsing, we do not have your most updated information. So once the PHE does terminate, we will be reaching out to update your contact information to actually send out the actual renewal packets to you to actually re-verify your eligibility. How in order to get there, we have to make sure your address information is correct. So we have actually done an experiment in California by sending out a massive mailer across the whole caseload. And we have received 12% return mail for the whole state. And that equates from a caseload perspective, that's about 2 million people that we cannot reach that may have moved without reporting it to the county or the state agencies. And that means there is a potential risk for them to be disenrolled for loss of contact. So it's very critical. So in terms of how we're just trying to protect our beneficiaries, kind of pushing the core messaging in terms of a communications campaign, which is very familiar nationwide, all Medicaid agencies are struggling with the same problem. The movement of people throughout the last 2 years has been unprecedented. In order for us to really help and really kind of focus and zoom in on how to help folks, we need to find them first. So phase 1 currently is underway in the state of California. We have rolled out an ambassador initiative where we're actually partnering with many CBOs, community-based organizations, consumer advocacy organizations. We have toolkits developed, and we have 19 threshold languages that are in the Medicaid program in California that we have translated all these materials. And knowing how important it is to reach many communities, we have a budget investment in the California budget that's currently being heard by the legislature to have a communications campaign of potentially using paid media in all threshold languages, similar to kind of the same momentum that we have gained through the COVID-19 vaccine pieces, and really learning from how to reach the demographics. And secondly, we are also using a health enrollment navigators pathway. We have a program in the state where we have $60 million invested in health enrollment navigators that focuses on underserved communities. So we have very tailored and customized type of communications and assisters out there in the community that we fund to really reach these populations. And they will be integral as we unwind the public health emergency, and they will be the trusted ambassadors that we're trying to push into the community. So one kind of interested to hear any other kind of ideas for the state, but they're certainly for kind of the context and kind of the circumstance we're in. We're trying to meet the moment as the government to really make sure we are helping anybody we can to keep them in coverage as this massive event does unfold. And just from a federal perspective, they see it as momentous as the Affordable Care Act. And I was here in 2013 when we were launching the Affordable Care Act in the state of California. And this is definitely one of those moments, very similar to healthcare reform. everybody is trying their best to really make sure we reach the most people we can to get them on coverage and help them remain on coverage. So that's kind of where we are in the state. Very familiar stories across the nation. All of us are struggling to really just do our best to help out, and encouraging folks to spread the word to all their current beneficiaries, just so that they could make sure they're retaining their coverage. Thanks.
And yeah, thank you so much for sharing. And this is work that is touching like every state in different ways, as a lot of our people in our audience are working on this issue. And it sounds like from California, you were applying lessons learned from the pandemic and also previous really big enrollment campaigns to really reach the people who need it the most. So that's really great insight to hear. So thank you for that. And finally, I want to turn to Sammy, and who's working on behavioral health and mental health. And my question is, as we all know, mental health is a significant issue for the AAPI community. Yet they face systemic and cultural barriers to accessing the care they need. So could you talk a bit about your work in this behavioral and mental health field for the AAPI community, and also just how it connects with everything that's going on in the world, as well as like, the hate crimes that are happening in our community, the public safety aspect of it as well?
Yeah, thank you, Kevin, and thank you for having me here today. So just to kind of give a little bit of background, so with Maryland, about 41.2% of Maryland's population, the Asian American population, actually they reside in Montgomery County. So Montgomery County is where we serve through the Asian American Health Initiative. So Asian American reflect about 15.2% of the county's population. So that's pretty huge for the minority community in the county. So mental health, it continues to be a major concern among Asian Americans. So looking at the general population, Asian American adults have the lowest mental health service utilization at about 4.9%. And this is consistent, even examining racial, ethnicity, ethnic use of mental health services by gender, poverty status, and insurance status. So furthermore, Asian Americans are also more likely than other racial and ethnic groups to believe that mental health services would not help. So we're working with a community that is already reluctant to seek care for mental health services, and navigation of mental health services it's not easy. Top that, we're trying to find a culturally responsive provider and addressing a linguistic barrier as well along the way. So as you mentioned before, with AHI, with Asian American Health Initiative, our mission is to apply to improve the health and wellness of the Asian American community in Montgomery County by applying equity, community engagement, and data-driven approaches. So to guide this process, we have basically 4 priority areas that we really focus on. So first one is community engagement. We conduct a lot of mental health outreach and engagement and educate on mental health topics, stigma, and also the model minority myths and more. Also, number 2 is community empowerment. So we provide technical assistance to empower the community, and this could be in form of development of educational material in the languages that meets the community's need, and then also development and implementation of evaluations as well. So even the evaluations, we have it in various languages, and then we try to provide that support to different community members and also faith leaders. Number 3 is capacity building. So just creating culturally and linguistically responsive tools and models for organization to adopt and utilize. So one of our options, or one of the examples, would be what we call our photo novel. Basically, it's an educational tool that talks about mental health issues in all age groups, from what is mental health, what does therapy look like, to what does social isolation look like, or what does stress, unique stress and unique pressure looks like in an Asian American youth. And then we basically have a conversation-based, basically this storyline that is guided by community members. We have focus groups to guide this, this sort of story, and then we also provide county level resources there as well. And then our fourth priority is changing catalysts. So that's basically influencing changes to improve the system. That is done by refining data, instruments to improve collection of Asian American data, enhance availability and accessibility of disaggregated data. And we also always try to sort of, educate the community that when we talk about Asian American, it's an umbrella term, right? There's, different religions, different languages, different culture, there's the East Asian, the South Asians, right? So, and I think somebody mentioned, always categorized as other Asians, right? About 17% of Montgomery County's population are also categorized as other Asians, and the majority are, Chinese, Korean, Vietnamese, and Hindi, and then you have this other Asian. So someone such as myself, who's a Nepalese Asian, would sort of fall in that other Asian category. So with the diversity in the Asian American community, the need is also very, very different. So it's important to kind of recognize that when we talk about mental health, issues facing Asian American community. And again, all of our, educational materials, they are translated into 16 different languages. Our resource brochures are, and then other educational materials are available in English, Chinese, Korean, Hindi, and Vietnamese. In terms of, with the rise of anti-Asian sentiment during the COVID-19 pandemic, there was sort of heightened anxiety, stress, and fear expressed by the community. Early research has linked the uptick in anti-Asian discrimination to increases in anxiety, depressive symptoms, and sleep problems among those who were targeted as well. So our response focused mostly on resource awareness, because what we found was a lot of, when the situation was very heightened at that time, a lot of community members were very afraid to report. Even, the older generations were saying, just keep your head down, just walk away from the situation, don't be in that situation. Or, the store owners, the small business owners were being targeted, but they did not know what to do about it. And they felt like, the system would not be helpful to them either. And on top of that, one of the major things was nobody knew how to report or where to go for report, right? It's like they felt like nobody was going to support, but then at the same time, they also did not know where to go to report. So we kind of focused, on developing flyers to address the increase in hate crimes and bias incidents, as well as highlighted some of the resources that were available to report crimes, legal resources, task forces that was, actively working on it. So the mental health resource guide that is on our website also highlights other community supports, and also for students within the MCTS, where to go for reporting there as well. So there was a lot of different things happening. So our focus at that time was mainly just bringing awareness on what's available.
Yeah, and thank you so much for that overview, Sammy, of what your organization and you are doing in terms of mental health. And it really does, I think it affects us all in different ways, but to see, how it affects our community in terms of the, current events that are going on, I think it's really important that we are continuing to listen to the community and also really take into consideration their voices. And that kind of ties into these next set of questions, which is open to all of our panelists. And that is, as all of you touched upon, our community is a diverse one with people who speak many different languages and lived experiences. And, how can we ensure that those in underserved, vulnerable populations, including the immigrant community, have access to healthcare and also have their voices represented at the table, whether it's setting policy or at government.
I can share my perspective, Kevin. That's a wonderful question. I think as government, we struggle with a lot of that, and obviously very dependent upon advocacy from the community to also share their perspective. But where we sit currently in California for our program, we translate into 19 different languages, including alternative formats for Braille, individuals who need large font, for example. And we try to, in all our communications and correspondence to our communities, to our beneficiaries, to have accessible language taglines as well as translation taglines and phone numbers that they are to call. All counties or all administrators of the program have access to translation services. Definitely, it's an area I think we have to acknowledge we need to work on even more in terms of all inclusiveness. I think that's a very important goal in my head in terms of, there's always more we can do. But I think there is that balance that we always have to keep in mind in terms of the folks that we work with. But I think for us in California, for sure, I can say we do have a very wide breadth and depth in terms of our reach into language access services, and likewise making sure we're communicating transparently to individuals that might not learn or speak or write the English language. So that's kind of where we are at.
I think from the sort of national federal perspective, there's been a lot of past laws that create a lot of barriers, especially for immigrant communities to access healthcare, one of them being the 1996 Welfare Reform Act, which barred certain immigrants from accessing things like Medicaid and other public benefits for 5 years. And currently, the health forum sits with protecting immigrant families and pushing the Lift the Bar Act. We're waiting. It's live right now. Senator Hirono, who is a champion for a lot of things, the AAPI community, the immigrant community. She is set to introduce the bill in the Senate sometime this week. So we're asking for a lot of support. If your senator hasn't, support the bill yet, please call and let them know to sponsor the Lift the Bar Act, which would lift this 5-year bar for a lot of green card holders and other immigrants who are prevented from accessing public benefits, including healthcare. And there's also other bills that we're supporting right now that touches on the issue of the 1996 Welfare Reform Act. There's also Heal for Immigrant Family, which is focused on healthcare, and other bills that are more pro-immigrant and more pro-access to healthcare for all. So we're really addressing the root cause of these barriers for immigrant communities. And I know that public benefits are distributed differently in different states, but at the end of the day, we need equal access for all immigrants, especially considering the fact that 65% of Asian Americans in particular are immigrants and live in immigrant households. So that's my big plug on healthcare access and improving healthcare access for the AAPI community.
Kind of echoing what's been kind of said in terms of course, healthcare for all. I know that at Humke Center at our local level, we have been, working towards the initiative of providing healthcare for all, as well as fighting for language justice. As Inga has mentioned, it's really important to have in language material. I think one of the biggest barriers in accessing healthcare, aside from having healthcare itself, is kind of getting accurate information. Where can they get healthcare? What kind of healthcare plans are there? I think it just kind of starts off with the fact that there are a lack of in language materials kind of relaying those kind of information, as well as, whether it's having physicians or administrators working at hospitals or clinics that may be able to communicate with those community members who may not feel comfortable speaking English. At least for vaccine equity work, there are websites where you can sign up for an appointment to get vaccines, but one of the barriers is that there's only English and Spanish languages available and not the other languages, especially for the Asian American community. And as you know, it's been said, Asian American is a huge umbrella. So although we recognize that it may seem impossible to have all those languages, it's kind of important to recognize that, as Aziza had mentioned, a large percentage of Asian Americans are immigrants. We need to recognize that it's important to have respective languages so people can fully get the information and understand what are the next steps in being able to pursue healthcare. So that's a little bit of my input.
I can add in a little bit. I think I definitely echo what Azia, India, and Sarah said. Language access is so important. Policy level work is very important as well. I think another thing is just to empower the community member too. A lot of times, what I've noticed is that even if first it's like in the Asian community, it's why do I need a healthcare? Why do I need insurance? Or why do I need to pay for this when I can save the money for something else? And even if health insurance is there, a lot of times they do not use it. They're not empowered to just go get a physical once a year, go see a gynecologist once a year. So I think that sort of advocacy for the community and empowerment is also needed on this end, not the policy end, but at least from the community end. So just to add on to what they already said.
One thing, Kevin, I think I forgot to share this. I can't believe I forgot. Just in that train of thought, in California, we have undocumented expansion. So healthcare for all, health for all, we call it here. First, we expanded to under 19 in 2016, and then it went up the age bracket 26 and under. And just in May, just about 3 weeks ago, we expanded healthcare for all 50 plus. And we're looking for a 26 to 49 expansion in the budget for approval. So truly, really trying to manifest that very important kind of theme here is providing, regardless of your immigration status, that we will provide you a full breadth of full scope Medicaid for all. So definitely a theme in the state of California. So very happy that I'm here and doing this work.
Oh, great that you remembered that. And yeah, just, I think those are themes that you all have touched on, just access and also inclusivity. And part of that wouldn't be possible, the wins that our community has won in terms of gaining health access, in terms of having a seat at the table, having their voices represented. It's because you all are leaders in your respective fields, whether it's in advocacy, policy, and in government. But my next question is, as leaders in the healthcare advocacy, public health field, are there any challenges that you've faced or have seen our community faced, and how have you addressed them? Or what do you need or want to advocate for so that we can all learn from each other and succeed?
I was just trying to see who unmuted. So for I think there's always room for improvement. I think that's why we need advocacy and people and organizations helping us to share the word. There's always room for improvement in terms of developing and moving forward better policy as times evolve. I think I've never seen so many different and rapid policy changes through my almost 9 years in healthcare at the state government level than the last 2 years was unprecedented. And the things that were brought forward, there's always room for policy windows. And I think COVID-19 left us not only lots of lessons learned, but left us lots of policy windows and opportunities for us to, that time is now, the moment is now. If you want to advocate to your government about certain areas, I think this is the policy window to do it, and opportunities are there. And I think we are at that point more receptive. I think just kind of reflecting on my 2 years kind of doing this work, kind of in this circumstance, that we are definitely more receptive and open-minded to more changes.
I think for me, oh, sorry.
Go ahead, Azia.
I think for me, as working at a national organization, is going back to the theme of representation, right? Representing the voices of our communities, and making sure that AA and HPI voices aren't an afterthought, that we are represented accurately in the data, but also in our voices, that the health forum isn't the only organization having a seat at the table, but we have space for other community members and organizations as well. And it's also changing the narrative of what AA and HPI is, whether we separate, disaggregate, but really changing that narrative that, you know, with mental health, that it's not always about social stigma, it's about culturally competent and accessible care that our communities don't necessarily don't want or are anti-mental health, but it's not culturally representative of the care that they need. So understanding those differences, understanding those different narratives, and making sure those narratives are heard and it's not singular and not monolithic.
I can add, through some of the work that we've done, one of the things we've seen is that Asian Americans are often portrayed as this like model minority, right? This myth that the model minority basically myth that a narrative that all Asian Americans are wealthy, healthy, acculturated, and have, higher educational attainment, and do not have any challenges like other minority groups. So this false assertion has undermined advances in health and wellness of Asian American, because this model minority myth basically assumes that Asian Americans do not suffer from health disparities, and Asian Americans have often been excluded from many national health databases, which has led to limited data on needs of this population. And I think another health consequences of this myth is that Asian Americans are frequently overlooked from receiving attention and resources, as they're perceived to have less health problems. So there was a study that even stated that model minority may contribute to doctors being less likely to follow guidelines and meet standard of care with Asian American patients in screening for chronic diseases. So it is important to dispel the model minority myth by viewing the Asian American community through this diverse, for their diversity and not just as an aggregate. So that's been a very important work that we're continuously trying to sort of advocate for as well.
Yeah, and just to add on to that, I think, as our panelists have talked about the lack of data and what contributes to that, whether it's a model minority myth or kind of working in the public health field, we learn about what population often has what disease or what illness, and a lot of the times I never really see a lot of data on Asian Americans. And, I think all of those factors that everybody has mentioned really contributes to that, which kind of gives the false sense of data of, oh, like Asian Americans don't have those other health problems, when often we're just really overlooked. And I think, another challenge with that is the underutilization of health services caused by the lack of trust. And, as Aziza had mentioned, it's important to have culturally competent narratives and providers and, folks who understand what community members are going through within the Asian American community. And then also all across the board, working in this vaccine equity project, I know within the community, but also public health officials and a lot of doctors and healthcare providers, COVID fatigue seems to be a huge challenge within, and a very common theme where, a lot of us are just not as motivated anymore, and everybody is tired of talking about COVID, and everyone is ready to move on, but with the reality that we are still in the middle of a pandemic. And so I know that a lot of them have mentioned, that they kind of have to switch gears of just keep reminding themselves that, their work does matter. And but it's also important for them to be kind to themselves as healthcare professionals and make sure that they take time for themselves so they can do better for the community. So those are several like challenges that I feel like I've personally faced, as well as heard from our community.
Mhm. Yeah, and thank you all for just sharing your personal challenges, but also your observations in terms of what the communities that we serve and also identify as have faced, and just ways to move forward and advocate for that. Now we'll have some time for Q&A from the audience. I do see one question. If you have any other questions from the audience, please feel free to add them on the Q&A section. But this one is for Yingja. Could you clarify? I think it was in one of the previous questions by what you meant by 300K for all age groups. I think you mentioned like under 19 through 65. Yeah.
Yeah, sure. So I was just trying to break down the 1.4 million of the folks that have shared that they were Asian on the application. And we look at it from kind of 3 age bands in terms of if you're a child, an adult, and then of course 65 and older. We look at it as a part of an aged, blind, disabled group, the aged group, and that's just for the purposes in terms from a Medicaid eligibility category. That's how we look at it from a coverage standpoint. And that's how we structure the Medicaid program. So we have about a little over 300,000 in each of the age band spreads across the distribution in terms of the 1.4 million individuals we have on our caseload that have shared that they are Asian on the application. So from an outreach standpoint, given the even spread, we know we need to have a very kind of global outreach tactics that target each of the age bands in our program.
I see. And thank you for that clarification. Let's see. So while we're waiting for, okay, we do see one. I think there is, someone had asked if California had 1.4 Asian American enrollees.
From our data, so just maybe contextualizing this a little bit more, the Medicaid application does ask what race and ethnicity do you identify with. It's optional, so we do have an unknown category. So most likely there is some underrepresentation in the data that we have, but for the folks who checked off the box for Asian, it is 1.4 million of the 14.6 million lives that we carry today.
I see. Yeah. Thank you for that. So we have time for one final question, and this is just acknowledging the diversity of our community, and that the AANHPI community is the fastest growing minority group in the US. And I want to pose this question to our panelists. Um, what led you to this field and what keeps you going?
Yeah, I can answer that question, Kevin. So I worked in public health, and I didn't really know what I wanted to do in public health at first. I did get my master's in maternal and child health, global health, and really at first wanting to work in that field, but also wanting to give back to the Asian American community as somebody who had realized that within our studies that, a lot of the data doesn't include our population. Why is that? Why is it that, we're never mentioned when there's an illness or disease? And as good as that sounds, I know that that wasn't realistic. And so, working at Humke Center where, we focus on underserved Asian American community members and learning more and more about vaccine equity and how, we are able to keep our community safe by working in this field. I keep thinking about the impact that I would be making, and really not just doing that, but also I know that I'm learning a lot through interacting with community members and really understanding the barriers and struggles that they may have aside from income status, whether it's mixed status, being undocumented, being a refugee. So just, learning and constantly feeling that I can somehow give back to the community and improving and keeping our community safe is what keeps me going.
Actually,
Oh, go ahead. You go right ahead.
I actually have an immigration background. So prior to coming to the Health Forum, I worked in both immigration practice and immigration policy. The policy side coming from Attorney General Javier Becerra's office. And my tie with healthcare with that is, he, under his administration, California defended the ACA. And that was part of the administrative law, not necessarily going into depth of health law or health policy. And then the immigrant aspect of it, immigrant policy aspect of it, was something I hold dear to my heart. This opportunity at the Health Forum came up, and it really, because we can't talk about, we can't talk about Asian American populations without talking about immigration and immigration populations, and the intersection of health and immigration really drove me to what I'm doing today, right? Fighting for immigrant access to healthcare and other benefits as well, and making sure that not only health is equitable, but all things are equitable for immigrant communities, whether they're waiting to come in or if they're already here.
And for me, I think I have an interest in policy. I have a degree in public policy. And I think when I was looking for a thesis to write, it was right at the moment the Affordable Care Act was launched, and it was on the front page of the New York Times. Took it and I ran with it. And here I am many years later as part of in government implementing the policies. And I deeply care about every night, like, am I going to drop anybody on coverage once the PHE ends? And I think that drives me to really kind of think and be thoughtful about what I do, and of course, kind of go through all the different kind of pieces to kind of get me there from a policy perspective.
So for me, being a 1.5 generation, right, 1.5 immigrant, I guess, just seeing my parents, my mom navigate the system, the healthcare system, the American life, the struggles, I think that was sort of like the foundation of why I pursued public health. But then, it was basically for me, my passion is to reach that pockets of community, right? Not who do not have the access, who are culturally or linguistically, very limited, or other barriers that they're facing, and the most vulnerable population. So that's where my passion was. So that's what kind of keeps me going, because if I'm able to make a change or difference in one person's life, that person has a family. that person may have a child, right? You're making a difference in a lot of people's lives. So that's sort of like a perception that I have when I'm working with the community. So yeah, that's kind of what gets me going. Just the hard to reach population, the most vulnerable population, just being able to make a difference there.
Mhm. Yeah, well, thank you all. I feel inspired just hearing from you. And this was a great discussion, and I just want to thank our panelists for their time and also for the audience. And after this webinar, we'll be posting the recording and any resources from our partner organizations, and please be on the lookout for that, as well as Families USA has a Health Equity Academy Fellowship, and the applications are open now, and so we'll also be sharing those applications, which are due on June 2nd. But yes, thank you all, everyone. We hope you have a great rest of NHPI Heritage Month, and yes, have a great afternoon.